Hello. Today we're going to remove EKOS catheter on a patient who came in with shortness of breath. She actually had a syncopal episode. CT showed she has a pulmonary embolism more on the left main. Yesterday she had a what we call EKOS or catheter-directed thrombolysis. Unilateral, so it was just on the left main, so she had that done yesterday. Just for a review, EKOS procedure, we do this for patients who has pulmonary embolism, DVT, and some arterial occlusions. So with this particular patient, she came with PE. There was some RV strain. That's why EKOS procedure was done. And I just want to show you here. So we have the Altiplace, which is your thrombolytic, and we use heparin, and then of course saline. And this is our actual, EKOS machine. So again, EKOS is a catheter-directed thrombolysis. You probably know this, but just a quick review. Your clot is actually, it has a stable clot, has like a very good fibrin, surrounding. So they use the EKOS. It has a pulsatile, mechanism that actually breaks, not really breaks the clot, but it helps open that fibrin strands so that your thrombolytic, which is your Altiplace, could go in and then dissolve the clot. So that's how it dissolves your, your thrombus. It's actually done through the IJ. So this is your catheter. Again, it's connected to the machine. So we're gonna take it out. So going back, so again, we have our, Altiplace, which is your thrombolytic, and then you have your heparin here, and you also have your saline. So, this is a catheter-directed thrombolytic management. So with, knowing that it's electricity, right, going into your left, main pulmonary artery, you always need the saline. The reason why you have the saline, because of the heat. So if you see some flashing here, like if you see some flashing, like it's flashing, you have to be mindful of that. You could actually increase your saline. Usually we have it like 30, 35. You could always increase your saline until the flashing disappears. Because the flashing actually means that it's the heat is so high. That's why you have saline running in there. And then you have your heparin. Of course, you want the blood to be thin, and then of course your thrombolytics. So now what we're gonna do, we're gonna stop it. It's unilateral, so only one side. So we're gonna stop this one now. Now we are on standby. And for our stuff, we have our, Caesar, of course, we have some gauze 4x4, and then, cleansing. So for infection control, of course. And this is our site. So, Miss, we can start doing this. And let me just show you here. So this is the actual catheter. As Asha is doing this, I will be doing this. That's your console over there, and we have this connector here. So this tubing is for your Altiplace. And then you have the coolant, which is your normal saline. That's what we're using. And the other one is your heparin. So it's good that the nurses actually, labeled it, so we know which, catheter, specific catheter is, there. Oh, okay. So Jamie's gonna turn off the 3 infusions. And we are actually gonna take the black electrical cord. This is your actual EKOS catheter that delivers the electricity. If you could pull that off, Miss Jamie, I'll have you do that. All right, so that's already off. And as Asha is doing this, we're gonna turn this off towards the patient. So that's off. This is off. And this one is also, we're gonna turn off. Turn off. So now nothing is going, towards the patient. Just more here. So, just use this. I'm gonna take this out. We're just taking out the dressing. I'm sorry, ma'am. And also, we monitor the patient's fibrinogen as because they're getting thrombolytics, right? So you want to make sure that it's not so high. I mean, it's not so low. So much tapes in here. It's actually just gonna. You know what, Jamie, you can stop the video for now and then. So, again, this is an EKOS catheter that we're gonna take out. They usually do this in the cath lab. They use an ultrasound, so it's an ultrasound guided catheter placement. So it's a catheter directed thrombolysis. So this is your actual, EKOS wire. So we already turned off the machine, all the infusions, your heparin, your saline, and your thrombolytics. So what we're gonna do is we're gonna take out the EKOS catheter first. So Asha, what we do, we just pull very slowly. So you wanna pull it, Miss Asha, this one here. So when I pull, I hold this and then, just pull this very slowly. So this catheter is actually sitting where the clot is on the left main, okay? And the thrombolytics that they give, it's a very low dose, so it has a potential, decreased risk for bleeding because it's a very low dose. They usually would leave this in for like 14. Some doctors, they leave it like 16, 18 hours. And then after that, we take out the EKOS catheter. So as long as there's no resistance, we slowly take it out. There you go. And yeah, good job, Asha. All right, so that's the tip. You want to make sure that the tip of the catheter is also intact, right? So what we have left here is the cordis or the sheet. So we have the sheet. This is actually just like where they introduced the EKOS catheter, right? So we could actually take this out now. When you take this out, always the same thing with central line, your PA catheters. You want to make sure that the patient is actually lying flat because you don't want any embolism, right? We all know that. Take this out. If I could take it out, of course. This is very tight. Okay, so let me use this. Can we raise the bed up a little bit so we don't have to stoop?
Is that fair enough?
Yeah.
Or do you want it like up? You need light?
All right, no. So we took out one suture. Now we have the cordis, so we're gonna take this out. And oh, you want me to just do it? So this is already out, right, Jamie? Jamie's gonna be popular in the Philippines. So always put like pressure here. especially the patient was on thrombolytic, right? So I'm gonna lower this a little bit, and as I pull this out, I put pressure. All right, let's support this. There you go. So again, you know, make sure that the tip is intact. And now, since the catheter is already out, we could actually have the patient sit up a little bit, and that would help also with you know, bleeding. I don't think she's bleeding, but you want to make sure that you put pressure in here. Again, this is venous catheter, right? Because it's going to your IJ. It's not arterial, but still. So if it's arterial, then usually we put pressure for like 20 minutes. This one, 5-10 minutes should be okay.